Why 1 in 10? Women have PCOS and don't know it. 1 in 10 women has PCOS. That's polycystic ovary syndrome, and most of them don't know it. Not because they're not paying attention, but because PCOS is one of the most misunderstood, misdiagnosed, and overlooked conditions in women's health. I'm Fleur, and today we're breaking down what PCOS actually is, why it's so common, and what you can actually do about it. Because here's the thing, PCOS isn't just about your ovaries. It affects your metabolism, your hormones, your mood, and yes, your relationships. PCOS acts like a third wheel in your relationship. And once you understand how, you can finally stop blaming yourself. Let's get into it. First, let's talk about what PCOS actually is. Because the name is misleading. Polycystic ovary syndrome. Most people hear that and think it means you have cysts on your ovaries. That's not quite right. PCOS is a hormonal and metabolic disorder. The cysts aren't actually cysts, they're follicles, little sacs that contain immature eggs. And having them doesn't automatically mean you have PCOS. In fact, you can have PCOS without having polycystic ovaries at all, and you can have polycystic ovaries without having PCOS. Confusing, right? That's why so many women go undiagnosed for years. So if it's not about cysts, what is it about? Hormones and insulin. Women with PCOS typically have elevated androgens. Those are male hormones, like testosterone. Yes, women produce testosterone naturally, but in PCOS, it's often too high. High testosterone in women can cause acne, excess body hair, thinning scalp hair, and irregular periods. But here's the engine driving the car. Insulin resistance. Most women with PCOS produce insulin, but their cells don't respond to it properly, so the pancreas pumps out more insulin to compensate. High insulin tells your ovaries to make more testosterone. High testosterone disrupts your cycle. It's a feedback loop that keeps getting worse. Think of it like this. You eat sugar, your blood sugar spikes, your pancreas releases insulin, but your cells ignore it, so your pancreas releases more insulin. That extra insulin goes to your ovaries and says, make testosterone. Your ovaries comply, and now you have high testosterone messing with everything. And by the way, insulin resistance doesn't just affect your waistline, it affects your arguments. When your blood sugar crashes, which happens often with unmanaged PCOS, your brain releases adrenaline and cortisol. You enter fight or flight. You might find yourself snapping at your partner, feeling irrational rage, or crying over nothing. We often call this being hangry, but in PCOS, it's a metabolic storm. If you notice your biggest fights happen when you haven't eaten in 4 hours, that's not a relationship problem, that's an insulin problem. So how do you know if you have PCOS? Let's talk about the diagnostic criteria. Doctors typically use something called the Rotterdam criteria. You need at least 2 out of 3 of these to be diagnosed. 1, irregular or absent periods, cycles longer than 35 days or fewer than 8 periods a year. 2, signs of high androgens, high testosterone in blood tests, or physical signs like acne, excess facial or body hair, or male pattern hair loss. 3, polycystic ovaries on an ultrasound. That means 12 or more follicles in one ovary, or ovaries that are enlarged. But here's the problem. A lot of doctors don't diagnose it properly. They see irregular periods and just throw birth control at you without investigating further. And because PCOS looks different in different women, it's easy to miss. Some women with PCOS are thin, some are overweight, some have severe acne, some have clear skin. There's no one-size-fits-all presentation, which is why it takes an average of 2 years, sometimes longer, to get diagnosed. Let's talk about the symptoms you actually feel at home. Irregular periods, cycles longer than 35 days, or skipping months entirely. Weight gain, especially around the midsection. That insulin belly. And it's not just about eating too much. PCOS makes it harder to lose weight because of the insulin resistance. Acne, particularly along your jawline, chin, and chest. Adult acne that doesn't respond to typical treatments. Excess hair growth. On your face, chest, back, or stomach. This is called hirsutism. It's caused by high testosterone. Thinning hair on your scalp. Male pattern baldness. Skin tags or dark patches of skin, particularly on your neck or underarms. This is called acanthosis nigricans. It's a sign of insulin resistance. Difficulty getting pregnant, because if you're not ovulating regularly, you're not releasing eggs regularly. Mood issues. Anxiety and depression are more common in women with PCOS. Now I want to pause on the symptoms for a second. Because in relationships, PCOS acts like a third wheel, and it attacks your intimacy in 2 ways, chemical and emotional. Chemically, low libido is real. High insulin and disrupted hormones kill your sex drive. But the emotional side is often harder. PCOS attacks the traits we associate with femininity: clear skin, smooth skin, thick hair, fertility. This creates what I call the femininity wound. I talk to so many women who are terrified of their partners touching their face because of stubble. Or they turn the lights off during sex because they feel shame about their midsection. This isn't just insecurity. This is a trauma response to your body changing without your permission. If you are pulling away from your partner, ask yourself, is it because I don't love them? Or is it because I don't feel safe in my own body right now? That distinction matters. Now let's talk about what causes PCOS, because this is where it gets complicated. The honest answer? We don't fully know. PCOS is likely a combination of genetics, insulin resistance, and inflammation. If your mom or sister has PCOS, you're more likely to have it. So there's definitely a genetic component. But lifestyle factors play a role too. Diet, stress, sleep, and exercise all affect insulin sensitivity. And insulin resistance is the underlying driver for most women with PCOS. Here's what we do know. PCOS is not caused by being overweight. You can be thin and have PCOS. But being overweight can make the symptoms worse because extra body fat increases insulin resistance. And PCOS is not caused by eating too much sugar. But eating a lot of refined carbs and sugar can worsen insulin resistance, which worsens PCOS symptoms. It's a cycle. And breaking that cycle requires understanding how insulin works. Okay, so what do you actually do if you think you have PCOS? Let's talk about diagnosis and treatment. Step 1. See a doctor. Ideally, a gynecologist or endocrinologist who specializes in PCOS. They should run blood tests to check your testosterone, LH, FSH, and insulin levels. They should also check your thyroid because thyroid disorders can mimic PCOS symptoms. They might do an ultrasound to look at your ovaries. But remember, you don't need polycystic ovaries to have PCOS. If you meet 2 out of 3 Rotterdam criteria, you can be diagnosed. Now, here's the hard truth. There is no cure for PCOS, but you can manage it. And for a lot of women, managing it well means the symptoms become minimal or disappear. Let's talk about treatment options. Birth control is the most common treatment. It regulates your cycle, lowers androgens, and can clear up acne and reduce excess hair growth. But birth control doesn't fix the underlying insulin resistance. It just masks the symptoms. So if you go off birth control, the symptoms usually come back. Metformin is a medication that improves insulin sensitivity. It's typically prescribed for type 2 diabetes, but it's also used for PCOS. It can help regulate your cycle, improve ovulation, and make weight loss easier. Anti-androgens like spironolactone can reduce acne and excess hair growth by blocking testosterone. For women trying to conceive, medications like Clomid or letrozole can stimulate ovulation. But here's what a lot of doctors don't emphasize enough. Lifestyle changes are the foundation, not because you did anything wrong, but because insulin resistance responds to diet and exercise. Diet. The goal is to stabilize blood sugar and improve insulin sensitivity. That means eating balanced meals with protein, healthy fats, and fiber. Limiting refined carbs and sugar. Eating at regular intervals so your blood sugar doesn't spike and crash. Exercise. Both strength training and cardio improve insulin sensitivity. Strength training helps your muscles soak up that excess sugar. You don't need to exercise obsessively, but consistent movement helps. Stress management. Chronic stress raises cortisol, which worsens insulin resistance. Prioritize sleep. Find ways to calm your nervous system. Supplements. Some research supports inositol, omega-3s, and vitamin D for improving insulin sensitivity and hormone balance. But talk to your doctor before adding supplements. And please, avoid the detox teas and extreme starvation diets. They stress your body out and make the insulin resistance worse. Now, before we wrap up, I want to give you a tool for your relationship. If you have a partner, they need to be on your care team. They don't need to be a doctor, but they need to understand 3 things. You can literally send them this timestamp of the video. Number 1, the fatigue is metabolic. Explain that insulin resistance is like a car with a clogged fuel line. When you're exhausted at 3 p.m., you're not being lazy. Your cells are literally starving for energy. Partner tip: if she says she's tired, believe her. Number 2, the insulin rage protocol. Create a rule. No heavy conversations when it's been more than 4 hours since a meal. If you feel that rage coming on, the answer isn't to argue back. The answer is protein. Stop the fight and eat. Partner tip: keep protein snacks around. Nuts, cheese, hard-boiled eggs. If she's spiraling, offer food before offering advice. Number 3, the safe space. If she's hiding her face or body, she needs reassurance. Partners explicitly telling her and showing her that you find her beautiful, regardless of a flare-up, creates the safety she needs to let her guard down. Say it out loud, say it often, and mean it. Let's bust the big myths quickly before we go. Myth 1, if you have PCOS, you can't get pregnant. False. It might take help, but many women with PCOS have babies. Myth 2, you have to be overweight to have PCOS. False. Lean PCOS exists. About 30% of women with PCOS are not overweight. Myth 3, you did this to yourself. False. It's largely genetic. You didn't cause this by eating sugar or not exercising enough. Myth 4. Birth control cures PCOS. No, it manages symptoms, but it doesn't address the underlying metabolic issue. So what do you do now? Track your symptoms. Even if your period is missing, track your mood, your energy, your skin, your hair. Look for patterns. Focus on insulin. Eat to balance your blood sugar. Protein, healthy fats, fiber, regular meals. Find a doctor who listens. If they just hand you a pill and say lose weight, find a new doctor. You deserve someone who takes PCOS seriously. And if you have a partner, show them that partner protocol section. Let them be part of your care team. Your body isn't broken. It's giving you information. And now you know how to listen. If this was helpful, subscribe. Next week, we're talking about fertility awareness methods, the 98% effective birth control nobody teaches you about. I'm Fleur. Thanks for watching.